My name is Naman Oyuki. I'm a medical psychologist and I'll take you through a presentation on motivational interviewing. So, do people naturally change when they know how important it is to do so? This is a question that most people struggle to answer. And in motivational interviewing, we attempt to answer that question. This presentation basically is to equip the staff at Oasis with the motivational interviewing skills so that they can foster change in patients, probably patients going through addiction cases. So, we are going to look at what is motivational interviewing, what is change and the stages of change, the underlying concepts in motivational interviewing, its adaptations and limitations. So, motivational interviewing is a counseling approach that enhances intrinsic motivation in clients to change by exploring and resolving ambivalence. So, it's simply an effective way of talking to people or patients or clients about change. It's effective because it's evidence based, it's been proven to work in so many people, and there are numerous publications that have proven the efficacy of motivational interviewing. And it was developed by two clinical psychologists, William R. Miller and Stephen Rolnick. Why is it necessary for us as clinicians to be equipped with motivational interviewing skills? I think it's useful in addiction treatment, even in dental health care, in physical activity exercises, in dieting and weight loss, in adherence counseling and medication adherence, in smoking cessation. Throughout our lives, we get faced with difficult decisions to choose, and sometimes we struggle to choose which way we'll go. Things like homework, things like marriage, things like addiction, accepting help often make people to be at conflict with themselves because they wouldn't do or what to choose. And normally in that state, or when change or when a negative behavior is hard to change, it's usually not about lack of information or laziness or being defiant or having a conduct disorder or even being denial. It's simply about ambivalence that we talked about that MIs tries to explore and resolve. Ambivalence is the state of wanting two different things at the same time, or two opposite things at the same time, or the state of wanting and not wanting to do something at the same time, and or wanting two incompatible things at the same time. So ambivalence normally leads to conflict and anxiety because it's uncomfortable, and it's a natural condition of being unsure about change. Everyone of us has experienced ambivalence. Many hard decisions in life, we have to go through ambivalence first before we make a stand or before we go through with the decision that we've made. So most often, when our patients are stuck or are in a state of ambivalence, we often confuse them to be resistant or oppositional or lack insight. And this is normally seen by counselors, psychiatrists, and nurses. They deem patient as resistant. These patients normally procrastinate a lot because they're conflicted, but in real sense, they're not even really resistant. They're just, for lack of a better word, confused. So, am I helped by exploring and resolving the ambivalence and enhancing that intrinsic motivation about the desire to change? And change is something that is very often talked about in motivational interviewing. So we'll need to know what is change and what are the stages of change. It's a concept that tries to explain how the stages people go through with negative behavior or addictive behaviors or addiction. And change basically is a state where is a transition between or a transition from one state to another, that is change. So let's look at the stages. The first stage is pre-contemplation. Most people in their lives have gone through this stage where you don't consider the behavior that needs to be changed as a problem because most probably you haven't suffered a negative consequence. They say someone who smokes a lot and they don't see smoking as a problem, that person is in the pre-contemplation state, like prior to thinking about it, prior to contemplating about stopping smoking, or prior to contemplating about stopping drinking, prior to contemplating about maybe addictive behaviors. And most people in this state are they can be deemed very resistant because they get very unreceptive of other people's opinion, or they are very unreceptive of criticism. And then from pre-contemplation stage you go to contemplation stage, basically where you think or you start to think deeply about the behavior or the problem that needs to be addressed and the behavior that needs to be changed. In this stage people have started to see how a problem maybe the negative behavior has become, or maybe how a problem maybe that drinking, or maybe their anger issues, or maybe their toxic relationship, or maybe their dental health has deteriorated and they need to go to a dentist. So basically starting to think deeply about making a change in your life. Contemplation to contemplation you go to preparation. In preparation, you've thought about the problem, you've thought about the negative behavior, you've come to a space where you see the need to stop or change that behavior. So you are basically putting things and resources in place for you to make a step towards changing. So the kind of things that happen in preparation stage is, you know, obtaining the necessary resources, getting rid of triggers, putting support in place. This can be an example is in smoking situation. Once someone has moved from not thinking smoking is a problem to thinking smoking is a problem, they need to set a date where they'll stop. That setting a date where they stop is basically preparation and moving the ashtray away, making sure they don't have the resources to buy cigarettes, all that is in the preparation stage. And action comes when maybe the date set to stop cigarettes, or the date set to really move toward, like, make the steps toward stopping that negative behavior or that addiction. That's the action stage, actually making the real change It can sometimes be stressful and uncomfortable as well. So, from action maintenance, which is basically maintaining that new behavior or the desired behavior, and in some places, it could be if you maintain it for 6 months or more, then you're in the maintenance stage. And the last stage is normally called relapse. And because of these stages of change, uh, is a concept that is heavily borrowed from addiction treatment. And having in mind how sometimes relapse is common in addiction treatment, relapse is usually put as the last stage. The idea is not to encourage people to relapse, but to just make them just be real that relapse is a common thing when you don't plan appropriately or when you don't handle lapses uh, uh, in the right way. Now let us look at the concepts in motivational interviewing. Number one is the spirit of motivational interviewing, uh, which basically looks at partnership. Motivational interviewing is a collaborative work between a client and the clinician. There is no expert, and in most cases, experts are encouraged to avoid the expert role. Clinicians are encouraged to avoid the expert role. And there is acceptance, which basically means you respect the client's decisions, perspectives, potentials, strength, and autonomy. Autonomy is the irrevocable right to make decisions about your own life. Then there is compassion, I mean, which is keeping the client's best interest in mind and being empathetic. Then there is evocation, which is basically best ideas about change comes from the client. As a clinician who is practicing MI, your ideas about change, you shouldn't impose them on the client. Then we can look at the core skills of motivational interviewing. The core skills are open questions, affirmations, reflections, and summary. These are very important skills in motivational interviewing, and we need to master these skills for us to elicit that intrinsic motivation, for us to explore the ambivalence, for us to even recognize change talk and change sustain talk into change talk. Those are things that we are going to look at in a minute. Then the third underlying concept is the four processes of the mind, which is engaging, focusing, evoking, and planning. So let us look at the core skills. Number one is open-ended questions. Open-ended questions basically helps the clients to talk more about what he or she thinks about his feelings and what's on their mind rather than the clinician talking. Because when a clinician asks closed questions, the clinician will be doing more of the talking than the patient. But we need the patient or the client here to talk. So they need to be asked open-ended questions. An example of open-ended question is how do you feel, as opposed to are you okay, or are you in pain, or are you happy. Another one is What role does alcohol play in your life, as opposed to do you have a problem with alcohol, or how much alcohol did you drink today, or how much alcohol did you drink last night? Did you go out last night? Another one is, what are the advantages of you stopping alcohol, as opposed to do you want to stop alcohol? So these open-ended questions basically helps to make the client talk more. Then there are affirmations, the ability to recognize anything positive in a client and reinforce it. You have to look at prior attempts in the client, you have to look at awards, you look at accomplishments, you have to look at achievements and affirm that, because all these help boost uh, client self confidence and self efficacy. There are two things that are very key in addiction treatment. So, examples of affirmations, or examples of how you can affirm a client, is basically saying statements like, it must be hard, but it's good that you're doing whatever it takes to be well, or it takes a lot of courage to come for a session even though you lapsed yesterday, or you must really care about your family for you to bring yourself to rehab voluntarily. So things like that help boost clients confidence and efficacy. So self confidence is something that really needs to be looked at keenly. A clinician should know when a client is, especially a client who has an addiction problem, let's say maybe has a drinking problem or marijuana cannabis use disorder, or maybe polysubstance use disorder, and they're so confident that they will change, or they will stop, or they will be abstinent of all the substances. Self confidence that is too much can work against the client, because the client may put him or herself in places that may trigger them into using. Like a person who was struggling with alcohol, went to rehab, got out completely motivated to stop, but is too confident to the extent that they go to the clubs, they go to hang out with people who drink, uh, hang out with them, drink. You need to really talk to them about not being that too confident, because they are prone to several triggers. Another thing is self efficacy, and a good self efficacy looks well on abstinence, because when you have good self efficacy, you generally believe that you're going to be abstinent, you believe in yourself, because addiction sometimes makes patients to be hopeless, or to think that they cannot come out of the problem. So when self-efficacy, basically the idea that you have it within yourself, the skills and the ability to change is up there, then these people can beat hopelessness and try to be abstinent. We can look at again another skill called reflections, which is basically trying to understand what the client is thinking and feeling, and saying it back to the client. This is probably one of the most important skills, because it makes the client feel understood, it makes the client feel that they are listened to. So, an example is when, like, a client can say, I don't think I have post traumatic stress disorder. And you say, okay, so what you're saying is that you're not sure about the diagnosis of PTSD. Or when a client say that I have been this way for a long time, I think it just must be, it must just be my personality. You can say something like, okay, well, it looks like you feel that this is normal. Or when a client says something like, well, I don't like having a conversation with my wife when I'm drunk because of the mess that normally follows and the picture it gives to my kids. So you can say something like, so you'd like to change the ugly mess caused by disagreements with your wife and the bad image your kids see because of your drinking. Then the last MI skill is summary, which is basically reflecting on one or more sentences. So someone can say several sentences like, I want to change, but I don't want to go to a rehab. I think I think my drinking is even not that much. If I go to rehab, I will miss my birthday. 3 months is too long. I'm way better off with you as my counselor. I can be coming to see you every week because I don't want to see another counselor. I don't want to tell my story afresh. So basically, you can just say, you can summarize all that by just saying something like, if I hear you correctly, you've decided to change, which is a very good place to be. But from your view, your drinking is not that too much to warrant going to a rehab. And besides, rehab take too long, and you'll be forced to miss your birthday and start therapy afresh with a counselor that you don't know because you don't want to stop seeing me. Yes. So we can look at the four processes of motivational interviewing, which is engaging. Uh, is the process of establishing a trusting and a mutually respectful relationship. Engaging is really important because if you don't engage the client well, the client will withdraw. And a way to not disengage clients is by not assessing unnecessary backstory or telling the clients what to do or playing the expert role or labeling the client. Another process is focusing. Is the process of seeking and maintaining one direction. This is obtained through the OR skills, that is open-ended questions, affirmations, reflections, and summary skills. You use that to focus the client in the direction of change and evoking the change talk and the motivation to change, and then planning and executing the plan. Once you do that, then you've done MI. MI can be a brief intervention or it can be adapted to into other therapy as we are going to see later on. Let's look at what change talk and what sustain. So change talk generally refers to statements about the desire to change, the ability to change, the need for change. And commitment language basically represents a more assertive declaration about change. When you hear clients talk about, I really don't want to relapse, I really don't want to go back there. It's a mess, I was in a bad place. Those are commitment change, commitment language. So examples of change talk is when clients talk about Uh, like, I guess this has been affecting me more than I realized. Basically, they're starting to see the bad side of the undesired behavior. Sometimes when I maybe drink, I just can't think or concentrate or work efficiently. Or sometimes when I go home or argue with my wife, or I guess I wonder if I've been, you know, okay or sane. Patient can say something like, I feel terrible about how my drinking has hurt my family. So those are change talk. They need to be recognized, they need to be reinforced. And sustained talk is basically the opposite of change talk. And most sustained talk, you'll hear them when a person is in the pre contemplation stage, when they don't think that they have a problem. You'll hear them talk about, I don't have a problem with cigarettes, I don't have a problem with alcohol, I don't have a problem with my wife or my family, or when uh, I can maybe drink without any problems, I can smoke without any problem, or when they say things like, I'm not the one with the problem, it's my wife, or I'm not the one with the problem, it's my brothers, it's my family. And then when you hear people say things like, there's no way I'm stopping cannabis, those are sustained talk, and these people are probably in the pre contemplation stage. And how can this stuff you evoke change talk to elicit the desired behavior change? By asking open ended questions, the way we've seen, by doing a decisional balance. This is called a cost benefit analysis. Look at the good things and the not so good things about the undesired behavior, and then the clients to be the judge. Look at the pros of stopping, look at the cons of not stopping, look at the pros of, yeah, basically being like that, look at the cons of changing. Then asking for elaboration, basically let the client talk more about how the undesired behavior that they are considering to change has affected them, has affected the family. Talk to me about how this has contributed to maybe the mess in your family. Talk to me about how your anger has led to uh, the toxic relationships. Through which is basically expression of empathy, shows acceptance and increases the chance of the counselor and the participant to develop rapport. If you explore, if you express empathy, the client will feel trusted, will feel valued, there will be trust, they'll feel respected, and they will generally trust you more. Develop discrepancy. Just look at help the client to see basically how the undesired behavior doesn't match with their goals and values, and then roll with resistance. Am I motivational interviewing is a non-adversarial, it's a non confrontational approach. You should avoid arguments at all cost, because arguments lead to breakdown in communication. So you have to roll with the resistance. Come up with new perspectives, but offer them, serve them in a gentle manner. Do not impose, and always try to listen to the client's perspective. And supporting self efficacy, which we said is a very crucial component to facilitating change. If the clients believe in the ability, they will most likely make the step towards changing. A person's belief in the possibility of change is an important motivator. Self-efficacy, I said, it's basically the idea that you have it within yourself to make the change that is required to be able to sustain that change. MY has been used in behavior change counseling, uh, which focuses in promoting behavior change in healthcare settings using brief consultations. MI has also been adopted in groups, which use basically has four phases and utilizes the four processes of MI, that is engaging the group, evoking members' perspective, broadening their perspective and building momentum for change, and moving into action. And then MI has also been used in motivational enhancement therapy, that is a time limited therapy. Limitations are MI is limited when there is an underlying mental health condition. Mental illnesses such as depression, anxiety, bipolar, schizophrenia, or psychosis requires more intensive therapy and may be required to require basically more intensive therapy because sometimes these people are delusional or they lack insight. And then people in the pre-contemplation stage may not consider that they have a problem that needs to be changed. So it may be difficult to use MI in this case. But if you grasp the concepts of MI and you know the skills very well, you can move someone from pre-contemplation to contemplation and even action. Then motivation is something that is sometimes underestimated, and simply advising clients about the detrimental behaviors and providing advice on how to change sometimes is not enough. Then MI is also limited where there is no trust between the therapist and the client, hence the need for partnership, the need for acceptance, the need for compassion, the need for evocation, the need to express empathy. And then there is training deficiency. Therapists know their own limitations. Basically, some therapists are not fully trained in offering MI. Then in group treatment setting, like the groups that we normally run in the hospital, you find different patients are in different stages. So it's really hard to get every patient on the same page. One is in the pre-contemplation stage, one is in the action stage, one is in the contemplation stage, one is in the relapse stage. So it's sometimes a bit chaotic. So there will I thank you for listening to this presentation and see you next time in my next project. Welcome.